Hello, we're very happy to meet you again. However, we cannot see each other, but still we're very happy to meet you again for the 7th and for the moment last webinar of the Institut de la Main. This webinar will be dedicated to upper limb spasticity, and we will go to the basics and then see what are the new research and the new treatments in that field. Remember that throughout the webinar, you will have a possibility to ask questions on the chat, and we will answer your questions either directly on the chat or during the discussion time. So this is how we are going to divide this webinar. We are first going to be discussing about definitions, clinical examination, and global evaluation of the spastic patient. We will then discuss the surgical treatment. If we could go on to the next slide, yes, that would be very, very helpful. Thank you so much. The principles of surgical treatment. And then we will look specifically and very quickly into a few procedures at every level, shoulder, elbow, wrist, etc. And finally, we'll talk a little bit about the future. So the previous slide was giving you all the names of the speakers. If we can go back very quickly to that slide, that would be very nice. Otherwise, it doesn't really matter. And each of us will introduce themselves. So the first speaker will be Nadine N.Sturbois-Nachef. She's formerly from Lille and now soon to be in Paris with us. She will be telling us about physiology and definitions. Nadine.
Good evening, everyone, or good morning for those who are from the United States, North America. So I will present to you now some few definitions. Okay, so let's begin with few definitions. You maybe know that the clinical picture of patients with central nervous system injuries is very particular. Maybe some of you don't have the experience of these kind of patients. So let's begin from peripheral palsy, the basis. Usually in peripheral palsy, it's very easy binary semeiology. There is one nerve injury and a muscular correspondent muscular palsy. So it leads to an imbalance between paralyzed muscles and normal active muscles. In CNS injury, the things are much more subtle and complex. You have on the one side the agonist muscles overactivity, which usually are the anti-gravity muscles, the flexors. And on the other side, the antagonist muscles hypoactivity, which are usually the extensors. There are several types of muscle hyperactivity. I will discuss about it later. As for the hypoactive muscles, we cannot talk about palsy as in the peripheral palsy because there are no any denervation of the muscles. There are several different etiology that we have to search for, and we will discuss about it. Muscle hyperactivity can lead to tendinous contracture, joint stiffness, and everything can change depending on the situation, the position of the patient, the temperature, the fatigue, etc. Moreover, we can find movement disorders. The most frequent is dystonia. We will talk about it. So first, the agonist muscle hyperactivities, 4 principal types. One of the most famous is the spasticity, which is an involuntary muscle contraction when performing a fast stretching. So it is due after a brain injury, you have an abolition of brain control on the spinal cord, and this leads to a myotatic reflex hyperexcitability. So here's a video. When performing a fast stretching of the flexor of the elbow flexors, you can see that there is an involuntary contraction of them and clonia. The second type of muscle hyperactivity is the spastic dystonia, which is completely different from spasticity and completely different from dystonia. Spastic dystonia means a permanent muscle contraction at rest, and it's due to an excessive supraspinal stimulation, no more inhibited by the cortex. For instance, in that patient, if we had used the EMG, we could see at rest a muscle activity of the wrist flexors and finger flexors. The third type is what we call the associated reaction, also called syncinesia. It's an inappropriate muscle contraction during a global movement. You may have seen already patients who, while they're walking, have an active flexion of the elbow, or while they're laughing or yawning. And finally, the last type of hyperactivity is the co-contraction. It's an involuntary antagonist muscle contraction during agonist muscle contraction. It is due to a loss of selectivity of the descending pathways with misrouting. So, for instance, if you ask the patient to extend his wrist, he will perform a involuntary flexion of the wrist. It's quite difficult to assess, and EMG might help. This was for the hyperactivity of the agonist muscles. Now, for the antagonist muscles hypoactivity, as I said, it's not due to a palsy because the muscles are not denervated, but it can have several etiology. First of them is a hidden activity by the antagonist spasticity or contractures. It can be also due to a lack of voluntary command. For instance, here is a video. I'm asking the patient to close her fist, and you can see that only her third finger is closing, and she cannot close the other fingers because she has a lack of voluntary command. Sometimes in functional limbs, you can have a lack of selectivity and coordination, what makes the things harder to assess. Finally, movement disorders. One of the most famous is the dystonia, which is a involuntary movement fluctuating in time. It is due to a basal ganglia impairment. We will see in the other topics that this is a contraindication to surgery. Thank you very much.
Thank you, Nadine, for clarifying so many of these words that we use, sometimes not always knowing exactly what we're talking about. Next presentation is going to be by Mathilde M.Gras, also from Paris, and she will tell us how to examine the upper limb of a spastic patient. Mathilde.
The examination of the upper limb is a complicated examination, so we will see together how to perform this examination. So we will first look at the spontaneous position, then the range of motion, the strength, the spasticity, we will check do some tests with botulinum toxin, and then we will test the antagonist muscle strengths. And we have to see also the sensibility of the patient and what is his function and what are the rehabilitation abilities of the patient. So the spasticity has already been described by Nadine previously, and you can see here the catch when we try to extend the wrist, the elbow, sorry, we can see the catch of the spasticity. So what are the etiology of spasticity? In children, we have cerebral palsy. Most of them are prenatal causes, but we also have perinatal cause or postnatal causes. It can also be infection or brain damage. In adult, most of the etiology are stroke or multiple sclerosis. It can also be traumatic brain injury or incomplete tetraplegia. So the evaluation is quite difficult because the spasticity is variable. So usually we do the evaluation with the multidisciplinary team, with the physiotherapist, the occupational therapist, the rehabilitation doctor, pediatrician, the surgeon. The examination has to be repeated several times in order to see if we have the same exams. And in the best cases, it's better if we can have some video in order to be able to compare and to check, and also to see what are the results before toxin, after the surgery, in order to be able to see the evolution. We first have to see the patient in its entirety. So we check if the patient can walk or not, if the chest is stable, how is the posture, does he has strength, sensibility, does he have pain, and what is his cognitive level, because it can also change the ability of the patient to do the rehabilitation, what are the daily occupations, and the ability of this patient with the arm he has already. Does he use his spasticity? Sometimes they can have a certain sort of use of the spasticity. And the spasticity can be variable according to the temperature, the stress, time of day, the fatigue, the concentration. So different factors can influence spasticity. So that's why it's very important to do several examinations if we need. So first we check the spontaneous position of the upper limb. And usually we have a contraction of the muscle with the shoulder adductor, elbow and wrist flexors. The forearm is in pronation position, and at the thumb level, we have a flexion and adduction of the thumb, sometimes thumb in the palms, and we can have different position for the long fingers, which are more variable. They can be a flex, swan neck, boutonniere, or different position. We can sometimes have other spontaneous position, but this is the more common position. Then we check at the range of motion. So we check at the active range of motion and the passive range of motion for all the different joints. So we check the shoulder in abduction into position, adduction, external rotation, internal rotation, retroposition, then the elbow flexion extension, pronation supination, the wrist flexion extension, the fingers, and also the anterocerus. We check the Volkmann and the thumb position. Then we check the strength of all those muscles. So all the results are reported here. And then we check the spasticity in those three places. So we check at the Ashworth and the Tardieu scales for the spasticity. Ashworth modified scale is a scale who can check the severity of the spasticity. So it can say if it's very spastic or not too much. And this is a very important information. Ashworth scale is a more common scale, but it doesn't give all the information. And we also need the Tardieu scale, which is maybe less known, but which is very important. And you can see with the Tardieu scale, we can report the V3, which is the angle where you have the catch. And you can see here, when we do, we really have the angle, and this is also important because sometimes you can have the same severity, but an angle which is really later, so the spasticity is less. And the Tardieu scale also can report some clonus in some cases. For the fingers, we will check the spasticity of the long fingers, and for the thumb, the extrinsic and intrinsic muscle. The botulinum will be explained a bit later in another talk, but for us, the botulinum toxin is very important, and it's a treatment itself, it will be said, but for us, it's a diagnostic tool, and it allows to see if when we decrease the spasticity with the botulinum toxin, if there is any stiffness or retraction remain. It can also unmask spasticity of some other muscles. For example, if you have spasticity of the fingers, if you put some botulinum toxin in the flexor superficialis and profundus, then you can see if you have also spasticity on the anteroserus or not. Then it can also allow to evaluate the strength of the antagonist muscles. And if we do the botulinum toxin in the flexors, we can see if we have extensors of the wrist, for example, and if they are strong enough. And we can do some rehabilitation because the botulinum toxin can stay for something like 4 months. So we have time to do rehabilitation and to see if there is enough strength in those muscles. And the other point is that botulinum toxin is a predictive tool of our surgery. And so it gives almost the same results than hyperselective neurectomy, and we will talk about this later, but it's a predictive force of the surgery. Then we check at the strength of the antagonist before the toxin and after the toxin with rehabilitation. We also check the sensibility of the patient, the basic sensibility with superficial tact, the pain, the temperature, and also complex sensibility with the proprioception and stereognosis. It's very important to know if the patient can feel, because if you have a hand who doesn't feel, you won't use this hand. So the sensibility is also an important part. Then we check the function with grasp evaluation. Here you can see the grasp and release. The capacity evaluation with 9-hole peg, which is this test, and the patient has to put all the pegs and to remove, and we check in 1 minute how many he's able to do. The box and block, the patient has to put the blocks in the other side, and we check in 1 minute how many he is able to do. We also check the capacity of the patient. There is it's with the multitask test, like MUL, CHU. There is a lot of tests who exist, and each rehab center use his own test. It would be nice to have all the same in order to know what we are talking about, but there is really a lot. And we really have a lot of tests to know what we are talking about, but any of them give all the results. So sometimes you can have some results with one test and some with others. We can also check the performance with bimanual test, and the ASHA is a very good test. It was at the beginning only for children, but then there had an adaptation for teenager and then adults. And this is an evaluation which is always the same with the two hands in situation, and we see if the patient use the hand, because there is something to see if he's able to do something, and the other thing is to see if he use it. And we also can use some daily life questionnaire. And then finally, we also use the house classification, which is a very useful classification because it gives a quick idea of what the patient is able to do. This classification goes from 0 to 8, and 0 is absolutely no use of the upper limb, and 8 is a spontaneous, normal use of the two hands independently, one to the others. This gives a very quick idea. Then we check the rehabilitation abilities of the patient. If he has pain, what is the family environment or accompaniment? Is the secondary benefits of the disabilities? What are the patient needs if he in his job or in his life in the house, does he need something special? What is the cognitive level? If the patient has a high level cognitive, he will be able to do rehabilitation with maybe transferred. But if the patient has a low cognitive level, it will be much more difficult to explain him how to do the rehabilitation. So sometimes the plan can also change according to that. And the rehabilitation is really the main important thing with the physiotherapist, the occupational therapist, rehabilitation doctor who are around the patient, who knows the surgery, who know how to do the rehabilitation and how to use the hand. And also it's important to have realistic wishes. The patient has to understand what we are able to do, what are the goals of the surgery, what he expected, and we have his expectation has to be the same that what we are able to do for the patient. So the examination has to be a multidisciplinary examination with rehabilitation doctors, physiotherapists, and occupational therapists. We assess the upper limb spasticity actively, passive spasticity. What are the capacity and performance of the patient? We have the classification of house. We use the toxin to decrease the spasticity and to have a complement of examination, and has a good setting of the goals. Thank you for your attention.
So as you can tell, this is not an easy task to examine the upper limb of a spastic patient. We wished also to put this upper limb inside the patient, and Jean-Gabriel Prévinaire. Sorry about this. Jean-Gabriel, who is a rehabilitation specialist in a very large rehabilitation center in the north of France, is going to tell us about the global evaluation of the patient and also about non-surgical treatment. Sorry, Jean-Gabriel.
Okay, thank you, Caroline. And in fact, yes, indeed, webinar rhymes with Prévinaire, so no problem with that. My talk will be mainly focused on spasticity in stroke patients. And so you've heard from the previous talk that clinical assessment for spasticity is very important. I will just add two things. First is that generic scales for spasticity, for focal spasticity, are usually not used because they are not sensitive enough for focal change in spasticity, and that there are now some possibilities for instrumental assessments of both strength and spasticity with specific devices such as the Tyro solution here. Stroke patients will often present with cognitive impairments that you must take into account in your assessment. When the dominant hemisphere is affected, aphasia is quite common, and it is the difficulty for the patient to understand what you say and or to express clearly their mind, what they want to say, and sometimes they will say yes when they mean no. When the non-dominant hemisphere is affected, left side neglect is quite common as well, and the brain kind of ignore the left side of the space or the body, so that here on the picture you can see that the patient doesn't see the left side of the drawing. He cannot reproduce it, and he will not see the left part of the plate as well. And it's the same for the body. The brain will ignore the left side so that the patient will underutilize her left arm. And another particular thing is apraxia, which is the inability to make purposeful movement or skilled tasks in the absence of significant motor or sensory impairment, and that will make the activities of daily living really difficult, such as coming here or drinking from a cup of tea, or dressing, walking, or using crutches, for instance. So at the end of your global assessment, you should be able to say whether spasticity is the main cause of the complaint. If not, is it orthopedical? Are there any cognitive issues? But if it is spasticity, is it focal or global spasticity? Is the spasticity useful or not? And if you're still, indecisive, selective motor nerve blocks can be very useful in the decision-making process, because with this you will be able to predict the outcome of the intervention, or sometimes to detect detrimental effect of the intervention. So keep in mind, it's been said already, but that spasticity vary by the period of the day. It can vary from one day to another, depending on many things. So that what you get in your consultation is not always necessary to reflect of what the patient lives in the activity of daily living at home. What is very important is to be able to determine clearly the goals with the patients, because the goals can be functional, or for the use of upper limb, or just comfort. But there's usually not one single goal, but many goals. You need to rank them, to prioritize them, and you must try and find a common ground between patient's expectation and what the medical team can propose with their intervention. And when it's a bit difficult, you can be helped by using some specific scales or tools like the goal attainment scaling, which propose a list of targets for intervention. And this scale is quite sensitive to changes following focal spasticity intervention, and provides as well a standardized measure of outcome. So, but for pharmacological interventions, very clearly, botulinum toxin has become first-line treatment for focal post-stroke spasticity. And in France, we are lucky to have 3 different brands. It's all the same. It's a botulinum toxin A. It's a neurotoxin that acts by blocking the neuromuscular junction, and it's a kind of chemodenervation. And the duration of action is approximately between 3 to 4 months, so that injection need to be repeated 2 or 3 times a year to maintain the same effect. Most of the time, the injection will be guided with the help of echography or EMG, and side effects related to the injection are usually very minor. Botulinum toxin has been used for upper limb spasticity in many cases, in many studies. And here is a study from a French team that followed prospectively 330 patients over a year. And what's interesting to see is that the goals for this injection are mainly for comfort, 2/3 of the cases, and in just 1/3 of the cases, it was for upper limb function. And the outcome found in that study is the same that many results of other studies, is that satisfaction was very high when the goals were for comfort or for pain release, but quite moderate when the goal was improvement in upper limb function. Interestingly, non-pharmacological interventions have emerged or have been reassessed recently. These interventions might be effective in treating spasticity, usually not as a standalone treatment, but most of the time in combination with a botulinum toxin injection. Still, the level of evidence with these interventions are quite limited, and you say that in the papers that review the effects, the evidence is considered moderate for acupuncture and for functional electrical stimulation. Acupuncture was mostly in studies for Chinese people, obviously, but we, in Berg, for instance, we use functional electrical stimulation after Botox injection. And very surprisingly, you can see that the level of evidence for using classical rehabilitation programs are low or very low, that in these interventions include passive movement or gentle stretching for spasticity, or passive or dynamic splinting, and other intervention as well. That doesn't mean that passive movement and stretching are not useful, but mainly for keeping a functional range of motion, but not for spasticity. Well, you can always use oral drugs, and in France we mainly use baclofen in stroke patients, but there are other drugs available, of course, but they all have systemic side effects that include drowsiness, fatigue, cognitive impairments, so that their use is quite limited. And you must keep in mind that they all have a general side effect with a decreased tone. So if you want to decrease spasticity of both upper and lower limb, it's okay. But spasticity can be useful for maintaining posture, for standing, for strength in the lower limb as well. So these drugs must be used with caution in stroke patients. So my take-home message is that you really need to define very clearly the goals with the patients, that a multidisciplinary approach is sometimes or very often necessary, and that botulinum toxin has become first-line treatment, but combination of therapeutic approaches can be very interesting. So thank you for your attention. Here is the bibliography, and that's it for me.
Well, thank you very much, Jean-Gabriel, for this overview that really replaces this upper limb in a patient with all his or her difficulties that we will have to take into account when deciding on surgery. How about questions? Charlotte, do you have questions from the chat?
Yes, we have two questions from the chat. So the two are from Mrs. Middleton, and they are both, I think, for Dr. Prévinaire. So I guess the second one, I understood it well. It's how do you assess the vision acuity of your patients, of these patients?
Well, for the acuity, it's well, the same test as for other people. The difference is that in combination with with neglect, you can have also hemianopsy, which is different from neglect, and that's a visual defect and not linked to brain dysfunction. And you must make the difference between hemianopsy and with neglect. But for the rest, for the acuity test, it's the same test as for able people. And so there are the different tests to assess a neglect, like reproducing a drawing or functional tests that can be proposed. But and there are also specific rehabilitation programs that can be proposed for those patients. But the fact is that left neglect can be very bothersome for the patients.
Well, maybe for the sake of time, we will go on to the talks, because we're already a little late, and we are going to enter into the surgical part of this webinar. I'm hoping. Okay. Just a few words before entering in each of the different surgical times. Defining the goal of surgeries, this has been already mentioned. It's extremely important to understand and to decide with the patient if we are going for function. And you see here learning this little child with CP how to use his spastic limb, or if it is purely comfort. And you see this chronic vegetative patient here is a totally different story. Sometimes it's only cosmesis, often in teenagers. Sometimes we want to prevent orthopedic deformities. Sometimes there are several goals, but this needs to be clearly stated and clearly understood by everyone. We obviously not all patients are candidates for surgery, and there are some contraindications. Dystonia to us is one of the main contraindications. It's extremely difficult to operate. The surgical blade doesn't do good, and I think we should really refrain from doing surgery on a dystonic patient. Major neurologic impairments also can be a contraindications, and in the case when we're doing functional surgery, we must beware of poor sensation, of apraxia, of lack of compliance of the patient, and probably most of all, of unrealistic expectations. And this must be really discussed before embarking on surgery. So we are faced with different causes of the deformity, and this has been explained earlier by Mathilde Gras. There is spasticity, of course, and this leads to muscle or joint contracture and muscle imbalance. Every single cause of the deformity must be treated. We try to treat them at the same time if possible. This has been referred to as single event, multi-level surgery, but I don't think this is so important. But we must treat all of them. So if there is spasticity, we want to reduce it. If there is contracture, we need to release it. And if there is muscle imbalance, we need to reinforce the paretic or paralytic muscles. So I'll be talking about selective neurectomy, and then we will go on to contracture and tendon transfer. What is exactly selective neurectomy? Well, it's a partial resection of a motor nerve to the spastic muscle. We remember that most muscles have different motor branches reaching it. So every single motor branch is going to undergo this partial neurectomy. So remember, this is meant only for spasticity. If there is muscle contracture, it must be treated otherwise. There are mainly two techniques of partial neurectomy. The truncular technique, you see here at the level of the trunk, and what we have termed the hyperselective neurectomy at the level of the terminal branches. Truncular technique is done through a limited approach of the trunk, and through electrical stimulation, motor branches are identified. And then part of them are resected, but at the level of the trunk. This technique has a great advantage of a limited approach. The problem is that it relies only on stimulation, however, we know that there can be great variability of motor branches anatomy, and some of the branches could be missed through this technique. And also because of the sensory motor nature of the main number of the main motor nerves, we might injure some of the sensory branches. On the other hand, hyperselective neurectomy, which was popularized by Brunelli, an Italian surgeon, consists in following the rami of the nerve until they enter into the muscle. And at this level, there is a partial neurectomy of each little ramus. The advantages of the technique is that it's absolutely selective. There cannot be any error in the target muscle. They are also harmonious. We can do neurectomy on each branch of the muscle. and there is no sensory disturbance. You can see here the entrance of the nerve to the FCR into the muscle. This requires knowing very precisely the anatomy of motor nerves. And before embarking on that surgery, we've done extensive anatomical dissections for all or most of the nerves of the upper limb. And you can see here for the musculocutaneous nerve, we have found 1 to 5 branches for the biceps, 1 to 3 branches to the brachialis, and the hyperselective neurectomy requires a long incision between 8.
Let's wait for Caroline to come back again. For the sake of time, I will continue on my presentation. I will present to you the lengthening, the tendon release in case of contracture. So as said, Caroline, if there is spasticity, the surgical treatment is neurectomy, hyperselective neurectomy. And in case of contracture, we use several techniques of tendon release. So there are two main types of tendon release, tenotomy and lengthening. Please don't confuse both of them. The first one, tenotomy, after performing tenotomy, the musculotendinous unit is no more continuous. As for lengthening, we keep a continuity between the muscle and the tendon. This is very important to understand. So the tenotomy can be performed either an open approach or percutaneously using a needle. If the tendon is superficial, of course. We use tenotomy if there is no functional needs of the muscle that is tenotomized, but we have to be aware of the antagonist status before performing tenotomy because there is a risk of hypercorrection. We're not obliged to immobilize after a tenotomy. Usually we immobilize 4 weeks if there is any skin tension or a risk of recurrence because of gravity, for instance, when doing a tenotomy of the pectoralis major. If no immobilization, we advise a multi-daily passive mobilization to avoid recurrence. Here's our example of hypercorrection after performing a tenotomy. The first case was a finger flexor tenotomy in a dystonic patient. Now you understand why dystonia is a contraindication of surgery, especially after if we perform tenotomy. And the other patient was a spastic patient who had a pronator teres spasticity and finger and wrist flexors spasticity, and he had been hypercorrected after these tenotomies. As for the tendon lengthening, there are different types. The tendon lengthening can be intratendinous, fractional, intramuscular, or we can use a muscular disinsertion. The muscular disinsertion, I won't talk about it. It's the Scaglietti procedure. We don't use it anymore in spastic patient because we have a less invasive solution in case of tendon contractures. So we will mainly talk about the two first types of tendon lengthening. So the tendon lengthening, the Z-shaped lengthening, is an intratendinous lengthening. The tendon, after being lengthening, will heal on the lateral borders of the tendon. It allows more than 3 centimeters of lengthening, and the immobilization is for 4 weeks. Here is an example of the biceps brachitendon Z lengthening. You can notice the position of the tendon after having extended the elbow, and in that case we perform a double running suture on the tendon to allow lateral healing. For a maximum lengthening of the finger flexors, we have particular procedures called the Brown technique or the STP procedure, which is the superficialis to profundus transfer. in non-functional hand, we cut the superficial tendon proximally here, and the profundus tendon, sorry, I inverted. We cut the tendon, the superficialis tendon distally and the profundus tendon proximally, and then we just open the fist so the two groups of tendons slide, and we can suture the superficialis to the tendon. This is for non-functional hand. We have to be aware of risk of swan necking of the fingers after this kind of procedure, and for arm supination. This is a peer-up view. The proximal is on the left, the distal is on the right, and you can see the FDS being sutured to the FDP, and the peer-up aspect of the hand, the assistant keeping the fingers in extension. This was a complete closed fist. The second type of fraction of lengthening is the fractional lengthening on the aponeurosis. We don't need any suture. Mainly, we cut the white into the red. The difference with the intratendinous lengthening is that the lengthening is maximum of 3 centimeters, so it's for small lengthenings. And we can theoretically immediately mobilize the patient postoperatively, but we prefer to cast the patient for 4 weeks to avoid any muscular tear during passive mobilization. Here are some examples of tendon being lengthening in the muscle. So here are the finger flexors, here the brachial muscle at the elbow, and here the latissimus dorsi at the shoulder. So beware of the safety zone to avoid muscular tear that has been described in a beautiful article written by Alam Arnaout and Caroline Leclercq this year. We have to respect a minimum of 2 centimeters proximal to the distal end of the muscle fibers. A little video to show you a pair up, yes, little video showing you a fractional lengthening of the FCU performed by Dr. Leclercq. So you can see we just cut the white into the red, and if you have a large safety zone, you can perform multiple intramuscular lengthening. So take-home message, if there is a contracture, we perform a tendon release. The tenotomy is used if there is no functional need and no antagonist overactivity. For short lengthening, we use a fractional lengthening. For long lengthening, we use intratendinous, and beware of the safety zone in case of fractional lengthening. Thank you very much.
Okay, so we will continue with the tendon transfer and the antagonist strengthening. So when we decreased the spasticity with hyperselective neurectomy, and if there is any contracture, we did the muscle tendon lengthening, as Nadine just told you. But sometimes we don't have enough strength on the antagonist muscle, and then we need to do a tendon transfer. So the antagonist strengthening is only for functional hands, and if we have a non-functional hands, there's no use to do it. So we will do tendon transfer and ECU centralization, which is also a tendon transfer. So how to choose the donors? To do a tendon transfer, we need a donor which is strong, the same like for tetraplegia. So we need at least a strength at 4 on a 0 to 5 scale. Which donor we can take? It could be the flexor capillaris, which could be spastic in some cases, because most of the time we have a spasticity of the flexor, and we can transfer it on the extensor capi radialis or extensor capi radialis longus or extensor capi radialis brevis. We can take a flexor of the superficialis, flexor capi radialis, the pronator teres, or like in this case, the brachyradialis to the extensor pollicis longus. So we can use different muscles, but what we absolutely need is to have a donor who can be sometimes a spastic muscle, but it absolutely has to get a voluntary contraction and relaxation abilities with few or no co-contraction. It means that if you transfer a spastic muscle, this muscle has to be able to relax, and this muscle has to be able to be commands with to be able to give a voluntary contraction in order to respond to the order. For that, we need to do a dynamic electromyography who gives the information, and you can see here that we have ability to relax. So, and we also check the co-contraction. The ECU is a special muscle because in most of the spastic patients we have a flexion of the wrist, a very important flexion of the wrist, and it's very common that we have a palmar subluxation of the extensor capillaris. The extensor capillaris goes to the palmar side of the wrist and become a flexor tendon. In that case, instead to have two flexor tendons, we have three flexor tendons. Two of them are spastic, and we only have the extensor capillarialis who can extend, and usually they are not sufficient. So in those cases, we need to do a centralization of the ECU and to transfer the ECU to the ECR in order to put it again in the dorsal side. So after a tendon transfer, we put a splint for 1 month. Then we do rehabilitation of the tendon transfer and with physiotherapy and occupational therapy. And we put the splint between the rehabilitation until we have an active mobility. Then the patient will continue to wear the splint only for the night. Here you can see the result after a transfer of the ECU to the ECRB, and you can see that the patient recover an active wrist extension. The contraindications are a spastic muscle without relaxation ability. If you have abnormal movement, you will have any good results with the tendon transfer. So abnormal movement is also a contraindication, and the patient needs to be able to understand the rehabilitation. So release the spasticity first, release the retraction with the tendon lengthening, and then if the antagonists are not strong enough, we can do tendon transfer in order to recover the antagonist movement. The donor has to be a strong muscle, but not too spastic. The rehabilitation and the occupational therapy are very important as all the time for those patients. A bit of bibliography. Thank you for your attention.
Thank you very much, Mathilde. I'm back. I don't know for how long because my connection seems to be very poor. However, I just wanted to share with you the conclusion of the presentation on selective neurectomy, because that was really the important part of the talk. So very rapidly, so we don't lose too much time, and please excuse me again for that. This was a study that we did. This is a 7 years prospective study, and it's just been published in the European Journal of Hand Surgery 2 months ago. And so 42 patients, 101 muscle, and the last follow-up is 30 months, mostly for elbow flexion, also pronation, and less for wrist flexion. And this is the results very rapidly. You see that the spontaneous posture of the upper limb after selective neurectomy has improved significantly. The range of motion, not so much, but we're dealing with patients, remember, who do not have contractures, they only have spasticity. The very good news about this work is that with hyperselective neurectomy, there is no loss of the strength of the muscles which have been neurectomized. There is a temporary loss for a couple months, but then it returns. And all the markers of spasticity show a significant improvement. And finally, the functional result as graded by the House scale shows some improvement. It's the same for the other results. We won't go into that. So the last thing I want to say is that if we look at the long-term follow-up, there is a little bit of recurrence of the spasticity, but to a level which is not significant and has not been found impairing by the patients. The goal has been attained in 92% of the cases, and this is the patient satisfaction. So we can say quite confidently that hyperselective neurectomy is effective on spastic upper limb muscles with durable results with preservation of muscle strength. Thank you very much, and again, sorry for this. We are now very quickly going to go into a few details of technical procedures because you also like to hear about this, and we are going to do 5 very quick 3 minutes presentations of specific techniques for each level. So Nadine N.Sturbois-Nachef is going to start out with the shoulder. Nadine, if you're ready.
Yes. I'm going to talk to you about spastic shoulder. So spastic shoulder is really difficult to assess as there are a lot of different muscles, but are very, the majority of them are very deep. It is very important to treat these shoulders because the patient can present pain issues in non-functional limb hygiene, closing issues, and in functional limb, it can impair the function and the prehension. The most frequent shoulder spastic deformity in adults is the medial rotation and adduction. It involves 4 main muscles: pectoralis major, latissimus dorsi, teres major, and the subscapularis. The pectoralis major can be palpated during a physical examination at the front of the axilla, while the teres major and latissimus dorsi can be palpated at the back of the axilla. The subscapularis is very difficult to assess because of its deep position. We will see few techniques, surgical techniques that we use for these 4 muscles in case of spasticity if the deformity is reducible, or contracture if the deformity is not reducible. For the pectoralis major, in theory, we could do a partial neurectomy in case of spasticity, and but the problem is with the lateral pectoral nerve, there is a lot of anatomical variations. So this neurectomy is quite difficult to perform. We prefer tendinous procedures and mostly a tenotomy. Lengthening can be done in a mild retraction of the pectoralis major, but the tendon is very small, so lengthening usually is not very efficient. For latissimus dorsi, both are possible. In case of spasticity, we can perform a selective partial neurectomy by an axillary approach. If there is any contracture, we can perform a fractional lengthening, as shown on this picture, at an axillary approach, or a tenotomy if the contracture is severe. For the teres major, as for the latissimus dorsi, both are possible: a selective partial neurectomy in case of spasticity, and a tenotomy if there is any contracture. Lengthening of the teres major is not possible because the muscle is very musculous and has almost no tendon. Here's a little video of a pair-up stimulation of the pedicle of the teres major that you can see on the back. For the subscapularis, it's quite difficult to manage this muscle because it's very deep. Its innervation is very multiple. So we don't perform an neurectomy because we won't be efficient enough. The muscle release, proximal medial muscle release is too invasive in adult surgery. So we prefer a tenotomy in case of a severe contracture. So to resume, if in case of spasticity, we can perform surgery on these three muscles. For pectoralis major, we prefer a tenotomy, and for the latissimus dorsi and teres major, a partial selective neurectomy. Doing surgery on subscapularis in case of spasticity is quite rare. In case of contracture, a mild contracture, we can perform lengthening of the latissimus dorsi and pectoralis major. And in case of severe contracture, we can perform a progressive tenotomy, beginning with the pectoralis major, and if needed, finishing with the subscapularis. Thank you very much. So Caroline Leclerc has lost her internet connection, so we will follow with Mathilde's presentation about a specific procedure for a spastic elbow.
We will check what are the operative procedures we can perform when you have elbow spasticity. For the elbow, usually we have a flexion elbow, which is the more common position. So the goal is to decrease elbow flexion. Rarely, in some cases, we can have some elbow extension, but it's really less frequent. The methods we have is hyperselective neurectomy and elbow muscle lengthening. So if we have pure spasticity, and to answer to the question, how to do the difference between pure spasticity or spasticity with retraction, we can assess it with the botulinum toxin, as I said previously. So when you do the botulinum toxin, it will decrease the spasticity of the muscle. So we can test before the surgery to do the botulinum toxin in the muscle. So for the elbow, we will do in the biceps and the brachialis, and sometimes in the brachioradialis. And now more often we also assess the brachioradialis. And if we have a pure spasticity, with the spasticity we decrease with the botulinum toxin and without any retraction after the release of the spasticity, then we can do only the hyperselective neurectomy, as Caroline Leclerc described previously. If we have spasticity and muscle retraction, then we will do the hyperselective neurectomy to the musculocutaneous nerve and to the branch of the brachioradialis, and also muscle lengthening. So for the biceps, we will do the Z lengthening, as you can see here, and as it already has been described. So we can cut the slide and then do a side-to-side suture. For the brachialis, we will do a fractional lengthening, and for the brachioradialis, we will do proximal disinsertion of the muscle. In severe retraction, we can also do biceps tenotomy when we really have a severe retraction in a non-functional hand. So this is a clinical case. You can see a patient with cerebral palsy, 32 years old, range of motion active of 60 degrees, 70 passively. The Ashworth is 2, and the tardieu is T2 with a V3 very severe at 120 degrees. And the patient had the surgery with hyperselective neurectomy at the musculocutaneous nerve, as you can see here, so with a big incision. And then he had the fractional lengthening to the brachialis and a Z lengthening of the biceps. And you can see after 20 months, the same patient with a really better position, and you can see a good function with the ability of movement of this patient. You can see that this will increase his ability of use of his arm. So elbow extension is really much more rare. If we have pure spasticity, we can do hyperselective neurectomy for the triceps only, and if we have retraction, we can do a slight fractional lengthening of the triceps. So first, decrease the spasticity. If we have spasticity pure, we can add muscle lengthening and in some case tenotomy if necessary. Thank you. So for the wrist and the fingers, what operative procedure we can do? So the goals are a bit different if we have a functional hand, and in those cases, the goal will be to rebalance the forces. And if we have a non-functional hand, we will decrease the spasticity and try to do a prevention of the orthopedic deformity and to avoid pain and facilitate the nursing. What procedure can we use? Hyperselective neurectomy, muscle lengthening, tendon transfer, and wrist arthrodesis in some cases. So usually we have more functional hand in children than in adults, but in some cases we can have also functional hand in adults. So we will check if we have a functional hand or not. And according to the deformity, if we have only spasticity, we will do an hyperselective neurectomy. So for the flexor capillaris, we will do a big incision to the ulnar side from the epicondylitis medial to the middle of the forearm in order to check all the branches for the flexor capillaris. And we will go to the median nerve in order to check the branches for the flexor capillary. Usually we also have a pronation, so we can also do neurectomy, hyperselective neurectomy for the branches to the pronator teres. And there's usually 1 or 2 branches for the pronator teres and 1 branch for the flexor capillary. And we can find them very easily at the first part of the median nerve after the elbow. Then, if we have a contracture, we can do some muscle lengthening, as we just described before. So we can do Z lengthening, we can do fractional lengthening, like here. So Z lengthening usually for the flexor capillaris, for the flexor capillaris, we will do fractional lengthening, and for the pronator teres, we can do a disinsertion of the distal part, distal tendon of the pronator teres. For the children, we will check if the hand is functional or not. If we have a potentially function of the hand, we check if the fingers are active. If the fingers are not active, so we will go back to a non-functional hand, like for the adults. And in those cases, we check the deformity. If we have a severe deformity, we will go for a total or mid-carpal arthrodesis. Usually in children, we will prefer a mid-carpal arthrodesis, so we will remove a triangle in the mid-carpal, and then we will close this angle and fix it. In adults, we will do more total arthrodesis, and we can do with this pin, like Nadine N.Sturbois does very often, or we can do a plate like those plates in order to fix all the radiocarpal. If we have a moderate deformity, or if we have a functional hand, then we will rebalance the forces in order to recover the functional hand and to use it. So we can do hyperselective neurectomy, as Caroline already described. We can do release of the contracture with fractional lengthening, Z lengthening, or disinsertion of the pronator teres. And if needed, we can do tendon transfer, as we have seen together previously. For the finger flexors, when you have a wrist inflection and when you recover some extension, and also sometimes just even already in the position of flexion of the wrist, you will have a finger flexors. So you also have to do a lengthening of the finger flexors in order to not to have fingers totally closed in the hand. Then we will do, we have a different type of lengthening. We can do fractional lengthening or Z lengthening for functional hand. And for the flexor pollicis longus, we usually do the fractional lengthening. If we have non-functional hands, and if we do a correction of the position, for example, with a wrist allodesis, we will more go to STP, transfer of the superficialis to the profundus, as Nadine already described, in order to have an easy opening of the hand, but with less function of the fingers. Thank you for your attention, and then Nadine will continue with the anteroserous and the intrinsic.
So I present to you two topics now about intrinsic finger interossei management, and afterwards the spastic thumb. So first, for the spastic interossei. Spastic interossei can cause issue with closing, or can be also painful. How to assess? There are two possibilities. Either there is a contracture or a spasticity. So how do we search for a contracture? We use what we call the Finocchieto test. So I will show you on this video. You extend passively the MP joint and then try to flex the IP joint. If this is impossible, it means that there is a contracture. But sometimes when you have a closed fist, it's difficult to extend the MP joint. So we use the modified Finocchieto test. We keep the IP joint flex and we try to passively extend the MP joint.
On voit pas ton partage, excuse-moi, mais il faut que tu mettes... Ouais.
Sorry for this. So I was talking about the Finocchieto test, so I'll show you once again the video so you can understand what we're talking about. We try to extend the MP joint and flex the IP joint. If this is impossible, it means that there is a contracture. In this video, there is no contracture. But the problem is in closed fists, it's difficult to extend the MP joint, so we use the modified Finocchieto test. We first flex the IP joint and try to extend the MP joints. If this is not possible, there is a contracture of the interossei. We can also measure the angle of retraction by this way. As for spasticity of the interossei, we perform a fast passive stretching of the MP joint in extension. We first flex the IP joint. Of course, you need to have supple joints and no contractures. You flex first the IP joint and fastly stretch the MP joint in extension, as in this video, and you can see the catch while performing the passive extension. It's difficult to assess the spasticity when there is a severe contracture, but you can have one indirect sign. It's the dorsal pain of the hand due to intrinsic muscle hypertonia. So now I'll briefly talk about the techniques. First, we have to assess if there is an interossei contracture by the Finocchieto test. If there's no contracture, we have to know if it's a functional hand or not. If it's not a functional hand, we can perform a complete neurectomy of the deep branch of the ulnar nerve. If it's a functional hand, we prefer to preserve the nerve and to use the Leclercq technique, which is the triangular resection of the dorsal hood. In case of interossei contracture, if the contracture is severe with MP joint stiffness, we perform proximal tenotomy, and in case of mild contracture, we perform a Leclercq procedures. So for the proximal tenotomy, in case of severe contracture of the interossei, we perform a two dorsal approach for the forefingers. We isolate the tendon of the interossei. We first look for the deep transverse metacarpal ligament, which is the palmar boundary, and then we just cut the tendon proximally. We use a palmar splint for 4 weeks, wrist in extension, so the splint does not slide, MP in extension, and then after 4 weeks we begin the physiotherapy. As for interossei spasticity, as I said, two situations, non-functional hands and functional hands. In non-functional hands, we perform a complete neurectomy of the deep branch of the ulnar nerve. You can see here that the deep branch on the left side runs down underneath the hypothenar arch, so this is a good landmark. Here on a per-op view, you can see in green the arch and the deep branch of the ulnar nerve in red going through underneath it. No post-op immobilization in case of complete neurectomy of the ulnar nerve. In functional hand, we prefer a littler procedure. We remove a triangular part of the hood, but beware, on the radial side we keep the palmar border, so to preserve the distal insertion of the lumbrical, and in that case we perform a post-op splinting for 4 weeks. Thank you very much. I will now continue with the thumb, spastic thumb, which will be a little bit shorter, I hope. So for the spastic thumb, we base ourselves on the Tonkin classification. The type 1 is an intrinsic deformity with the flexion of MP joint and extension of the IP joint. The type 2 is the extrinsic deformity with mainly a flexion of the IP joint, and the type 3 is the combined full thumb and palm deformity. For the type 1 in intrinsic thumb, the same way of thinking. If the deformity is reducible, we are in front of a spastic deformity. We can perform an hyperselective neurectomy for the adductor and the first interossei. We can search for the branches between the two heads of the adductor. As for the other muscles, intrinsic muscles, we can perform a HSN on the thinner branch of the median nerve, as you can see on the picture. In red, you have the median nerve, and in blue, the little branches that go into the intrinsic muscles. We perform a partial neurectomy in case of functional hand, and total neurotomy if no functional. All these procedures are performed via a approach in the opposition crease. In case of contracture, if the deformity is not reducible, for functional hand, we perform a proximal release as described by Matev, and in non-functional hand, we can perform a distal tenotomy at the phalanx area. And sometimes in this deformity, there is a deficit of the EPB, the extensor pollicis brevis, and we can, in this case, if there is an activity of the EPL, to perform an EPL tenodesis at the proximal phalanx base, as in on this drawing, and you can see this pre-op hand in a patient operated by this procedure, and the post-op aspects of the thumb. For the type 2 in extrinsic thumb, if reducible, we can perform a FPL HSN. This has been described in in an article wrote by Katharina Parot and Caroline Leclerc. And if it's not reducible, there is an FPL contracture. We can perform either fractional lengthening in case of mild contracture, or intratendinous lengthening or tenotomy in non-functional hands in case of severe contractures. Finally, for functional hands, when there is a paralysis of the extensor muscles, we must rebalance the forces. We can perform tendon transfer. We have several muscles that can be used. For the recipient muscle, we can either use APL, EPB, or EPL, or a combination, but we need to test it pair up by pulling on the tendon and by looking what movement can perform the thumb, and of course you must stabilize the MP joint in case of hyperlaxity. So for the spastic thumb, we use the Tonkin classification. In case of spasticity, we use HSN associated to a release in case of contracture, and most important, rebalance the forces. Otherwise, there is a risk of recurrence in case of no antagonist. Thank you very much.
So Charlotte will talk about the future.
Yes, so hello everybody. I'm going to share my presentation here. So I'll talk about nerve transfer. So is nerve transfer the future? So as you have understood now, the spastic upper limb management goes with the decrease of the spasticity, the decrease of the contracture, and the reinforcement of weak muscles. To reinforce weak muscles, till now we've been using tendon transfers, and the question is, can we use nerve transfers? And can we associate nerve transfers with the neurectomies we're doing for spastic muscles? So nerve transfers are used now as an alternative strategy to nerve graft repair, also for avulsion injuries and for proximal or delayed injuries. They've been using recently for spinal cord injuries, but only healthy donor muscles were used. And the goals of using them here would be to reduce the invasiveness and the operative time, to ease the rehabilitation protocols, and to decrease the length, the duration of the immobilization time, and to provide a finer control, and eventually to combine them with the neurectomies that we're doing on spastic muscles. So where should we do the neurectomy if we want to associate it with a nerve transfer? So the ideal area would be at the selective level, and would be for muscles with multiple branches. So if the muscle has only one branch, then it's not really possible to associate a neurectomy and a nerve transfer. But if it has multiple branches, then you can cut one branch at a selective level, transfer it on the recipient muscle, and then eventually add another hyperselective neurectomy on the other branch if needed. So what's the theory behind all of this? Well, these patients, in fact, suffer from generally cerebral palsy, stroke, or traumatic brain injuries. And so they have a loss of the upper motor neurons only, and the lower motor neurons is usually healthy, with the motor units still functional. So there's no time constraints to reinnervate these muscles. Also, when we'll be cutting one of the branch of the motor nerve, what will happen is a collateral sprouting of the motor unit, the residual motor unit, and one motor unit can cover up to 5 times the original area, its original area. And also for the recipient muscles, there would be no spasticity, because there would be no regrowth of the sensory fibers that lead to spasticity from the donor nerve. So usually the patients present like this. That's a classical patient spastic upper limb. And the donor muscles that would be the strong and spastic muscles that are listed here. And you see it's the wrist flexors, elbow flexors, pronators, shoulder adductors, and internal rotators. And the recipient muscles are listed here. They are the weak and contrasted muscles that we are aiming at. So, but be careful, because there is a lot of variability in these presentations, and you have to do a very thorough exam before indicating a nerve transfer or neurectomy. We've been studying these nerve transfers, and till now it's been anatomical studies only, but we've been trying to associate neurectomies of these muscles here with nerve transfers of the branches from these muscles onto the muscles, the recipient muscles here, the weak one. So we've tried to do the neurectomy of the brachioradialis muscles muscle, and we know that the brachioradialis has from 1 to 4 branches, and it's usually very close to the ECRL, so it can be transferred on the ECRL when neurectomized, as you can see here very easily. And you have the results in the article just below the picture. And here we've been also trying to use the PT branches, so pronator teres branches. Usually the PT has 2 branches, so it's a very good muscle to use for nerve transfer. And the most interesting one is the distal pronator teres branch, which is long, and that can reach the PIN, but also eventually the ECRL and the ECRB, and also the AIN if needed. The proximal is also usable, but it's less. It's shorter. And for the FCR, the FCR usually has only 1 branch, so it can't really be used to do a nerve transfer with a neurectomy at a selective level. So these results are only from preliminary works, and they are on the combination of neurectomy and nerve transfers. Remember that there is a lot of variability with the clinical presentation and the anatomical presentation, so you have to do a very detailed preoperative examination with the strength, the spasticity, and the contracture of the muscles, and to be able to indicate a neurectomy and eventually with a nerve transfer, but you have to make sure it's possible with your intraoperative findings, and only with these findings, because there is variability in the anatomy, you can then confirm the feasibility of it. And some clinical studies are in process, but we don't have the results yet to show to you. But eventually, in 1 year, we'll have some results. Thank you.
Thank you, Charlotte, for this beautiful presentation and for those options for the future in order to have another way to recover the antagonist strengths. And Caroline will take the talk for the end.
Well, again, I'm sorry. I'm sorry for disappearing several times, but it's very reassuring to see that even when I'm not there, the show goes on. So thank you to all of you. There is maybe time for 1 or 2 quick questions. Charlotte, you mentioned something about spasticity and contracture, correct?
Yes, correct. It was an earlier question from Parag Shah.
Okay.
And he was asking, how can you differentiate spasticity from contracture?
Well, that's a very good question. It's difficult, especially when spasticity is severe. Normally, spasticity is known to yield after at the end of the movement, whereas contracture is permanent. You cannot fight contracture, but sometimes it's very hard. In such a case, the botulinum toxin is a great tool, because the botulinum toxin will help the spasticity to diminish or to disappear, whereas the contracture remains. For this reason, and not only for this reason, but that's one of the reasons for us to use botulinum toxin almost systematically after first examination of a patient, and then we will see the patient again, usually 1.5 months or 2 months after toxin has been performed in the target muscles we are interested in. Our views on toxin are very different from rehabilitation doctors who use it as a treatment, even though it's not permanent. We use it as a diagnostic tool to differentiate between spasticity and contracture, to evaluate the antagonist muscles. This has been said before in this webinar, and so we really appreciate to have this tool, and sometimes we will even do 2 sessions of toxin in order to be more precise about the difference between those 2 components. Was there any other question?
We have, I think you answered some of it, Caroline, but we have a question here. Will the results include the rehabilitation? I don't know what Mrs. Middleton is talking about, the results of the...
I think she was talking about the nerve transfer. You said that you will present the result in 1 year, maybe, and yes. So she wants to say she wants to ask you if you will include the results the rehabilitation too.
Yeah, the rehabilitation protocol, I guess, or...
Yeah.
Okay. Yes, of course.
We need to be patient. If any of you has any other comment?
After tendon lengthening, how long splints during night?
Well, for the tendon lengthening, usually we perform a permanent splinting for 4 weeks. And then it depends of the patient, the degree of contracture, but usually for 1 month more, we use a part-time splinting during daytime, but also during at night, approximately, yeah.
Okay, I think that we are going to close up now. I see more questions coming, but we're sorry, we do have to go to an end. Remember that you can replay this webinar. You will, all of you who have been connected will get the link to the replay, and you can also visit the site, the website of the Institut de la Main, which you are seeing here now. As I said early on when starting this webinar, is that for the moment this is the last webinar of the Institut de la Main that we are going to be doing in this moment, and we wish to concentrate again on our symposium. We've been doing symposia for I think 30 years. We were very disappointed that we couldn't run them for almost 2 years now. So this is for the moment, this is our goal, to start the symposia again. Very shortly, we will let you know what and when the next webinar will be. Probably in autumn of 2022, but there is still some debate on that. So thank you all the participants. Thank you obviously to all the speakers. Again, you did a great job, and I feel I was not needed, so it was perfect. And thank you to Hélène, who is in the backstage. And hope to see you all very soon. Bye bye.